wait for, you agree to start. طيب. What do you think, our speakers? Would you like to start? طيب. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على نبينا محمد وآله وصحبه أجمعين. I would like to welcome you all, and first of all I would like to introduce myself. I am Dr. Ahmed Abu Abad. I'm a rehabilitation consultant at King Fahad Medical City. At the same time I'm لا هذا متابعك لا كل الاثنين تبعي
لانك كنت تارك كان كثر الجلسه هنا تارك
شلون
فيها توصيات
لا ما فيها توصيات لا thank you doctor. So I'm also a CARF surveyor in the rehabilitation facilities, and I would like to welcome you all in this session. In this session we have different speakers from different background. We have Ahmed Al-Huwaymil, and we have Bara Muhammad Yusuf, and we have Mazid Al-Ataybi, we have Dr. Mustafa Saleh, and we have Dr. Abdul Rahman Sbihin. So we would like to start with Ahmed Al-Huwaymil, and Ahmed is I'm proud to be a colleague of Ahmed while he was a physical therapist at King Fahad Medical City. Ahmed has a good experience in physical therapy in different private hospital. Currently he is a PhD candidate from Nottingham in United Kingdom. Personal experience, I know Ahmed, he is a very excellent therapist in musculoskeletal and in the upright mobility, and he has a good experience. He has as well winning the best researcher as well from the Spine Society, and Dr. Ahmed will talk about the application of advanced MRI in low back pain or chronic low back pain. I am sure this is a very interesting topic, and it's a unique as well for physical therapists as well. So I would like to welcome Ahmed Al-Huwaymil, or fortunately, or inshallah, Dr. Ahmed Al-Huwaymil.
Inshallah.
Hayyak Allah.
Thank you, Dr. Ahmed, for this gentle introduction. Thank you all for coming. The topic is the study about the relationship between MRI diagnosis and psychosocial factors that's associated with the diagnosis in chronic, non-specific low back pain patients in Saudi Arabia. So this is the outline of the talk. So we're going to have a few introduction slides about the chronic low back pain in general. And we'll briefly discuss the framework which we utilized for this study, and what's the project methodology, and what's the results of these studies, and finally the thank you. So we know that back pain is affecting more than 3/4 of the population will have experienced at least one episode of back pain once in their life. Out of this 3/4, almost 1/4 will suffer from recurrent, non-specific back pain patient, where you cannot associate a pathoanatomical diagnosis to it. We know that MRI is a preferred procedure in diagnosing pathoanatomical disorders, like studying the existence of pathology. And sometimes we have seen studies that have focused on the asymptomatic population, and we found a lot of abnormalities in this population. The worries is that we have overutilized the surface of MRI, and it has been published in many articles worldwide, not in only one country. There are for sure negative effect of overutilizing MRI scans, One of them is, of course, the higher cost of MRI scans, and that we're not putting the money in the right pocket. The current clinical guidelines suggest that we don't use imaging at all, not only MRI, for back pain in general. So we should see a red flag sign or symptoms to refer patients for this kind of radiology. And there is an evidence that the use of this procedure will, as I said, will increase the cost of care for back pain patients. So we aim by this study, since we're doing mixed method study, we have two primary aims. The first aim is just to explore the psychosocial changes in non-specific low back pain patients after obtaining the MRI, and if there is any. And the second aim is to determine the feasibility and the acceptability of randomizing patients to receive MRI or to be allocated a non-MRI group. So with this mixed method study, we utilize the framework, MRC framework for complex intervention. This framework suggests that there is no simple intervention. That's PICO is what we know as the perfect formula to design interventional studies. Patient population intervention, control or comparison, then outcome. But in real world, there is no such thing that can be applied in every clinical scenario. So we should use something like context dependence. What we have used in one country cannot be applied to another country. What we have used to certain patients cannot be applied to another patients in different population, different ages. And so the framework, the MRC framework suggests the social and economical, political, organizational characteristics of the setting in which intervention takes place have to be considered when designing an interventional trial. So it's basically start with a preclinical stage, which is generating the theory or getting the theory right. It could be obtained from a literature search or from systematic review study. Then you go to do the first phase, which is the modeling phase, by conducting in-depth interview study with those who might be involved in your clinical trial. There could be patients, stakeholders, clinical practitioners, or anyone with direct or indirect attribution in the study. Then you go to the exploratory phase, which is phase 2. Exploratory phase is testing the water before you dive in the water. So you just do a feasibility study or pilot study to test if it's feasible to go ahead for definitive trial or not. So by adapting such a model, we know that we're not gonna waste our time or money to implement a definitive RCTs when it cannot be implemented in the context of Saudi Arabia. So lately there's a change to the MRC framework to adapt non-sequential phases of it. So they start to add a process evaluation for it to assure the feedback of the patients or of the clinical practitioner to be considered. For example, when conducting the study, at certain times you might notice something not working very well, like low recruitment. So you should stop your study and do a process evaluation of the study. And this process evaluation, you might discover what are the factors that's behind the low recruitment rate. Then you go ahead and amend it in your protocol, and therefore you could achieve your targeted participation. So the methodology that we use a sequential exploratory mixed method design, in which we use the qualitative study, first stage, then a quantitative study. So we use a qualitative interview with patients, physiotherapists, and doctors. And the reason we have chosen this method is just we don't know what are the psychosocial factors. It could be stress, it could be fear, it could be depression, and we don't know what to test in the clinical trial. After that, we have conducted a feasibility RCT with nested process evaluation. So within this process feasibility, we have a small qualitative study from the same population. So we basically basically part one is can be used in qualitative study, then the explanatory trial, which is the feasibility study. So in the qualitative interviews, we've interviewed 12 patients, 6 therapists, and 6 spinal surgeons in one-to-one semi-structured interview. All these interviews have been transcribed in the same language, in Arabic language. Then we have adapted a thematic analysis to identify the themes of these interviews. We have 4 main themes emerged from these interviews. These themes are patient education, impact of pain in people with non-specific chronic low back pain, MRI use in people with non-specific chronic low back pain, non-specific chronic low back pain management in Saudi Arabia in general. Of course, the findings of the study is, of course, lack the generalizability or transferability because it's been taken from small sample in one center in Saudi Arabia, in Riyadh, Saudi Arabia. So you cannot generalize the findings to the whole country of Saudi Arabia. First theme is the MRI use in people with chronic low back pain. Patients have reported higher fear and anxiety after obtaining the MRI diagnosis. And this fear and anxiety have been associated with less mobility from the patients. So they've mentioned, like the quote below, that they have more anticipation for the pain now, and that's restricting their movement and overall. The second theme is the impact of pain in people with chronic low back pain patients. This is not a new theme. Many studies have found this similar things, that low back pain patients can badly affect patients in many aspects, psychosocial and economical aspects of their life. Third theme is the management of chronic low back pain patients in Saudi Arabia. It should be in one center in Saudi Arabia, cannot be generalized to the whole country. So the participants, whom are mainly physiotherapists and spine surgeons, have raised concern about the management of back pain patients. They mentioned that we have lack of specialties, lack of resources, mainly in primary care setting, which the clinical guidelines suggest should be the first-line approach of management for such cases. And they have they have also reported that this lack of resources and staffing and primary care have resulted in low trust from the patient to attain their treatment and such level of care. Patients are more into secondary care level of treatment. They have more trust, and that leads to more a waiting list and the treatment, and therefore more chronicity for the cases. The last theme is the patient education. We have discussed this with our participants, whom are physiotherapists and doctors, and they have different background in the education. Some of them, very little of them, are adapting a pain education and biopsychosocial education background, and the majority are relying on biomedical background, like the quote below. They're just describing what is in the MRI, or describing in the model that this is happening in your spine. None of them none of those who adapted the pathoanatomical approach is using a reassurance for the patients. So after these findings, we have two main factors that we want to study in this type of population, which is the anxiety and fear. So the next study is feasibility RCT, in which we have randomized patient to receive MRI or have no MRI, and follow them up after finishing their physiotherapy treatment. The study length was 4 months due to the regulation of the sponsor of the study. We were able to screen 129 patients. Most of them, the majority, have been was excluded due to from those excluded, almost 80% of them excluded due to having MRI before 3 months. So majority have MRI before they come to secondary care level. So we have only 16 that been randomized to have MRI or no MRI. We have dropped out of almost 40% from the whole randomized people, and we were able to analyze pre and post 6 in both arms. So this is the age or the demographics of those who've been randomized to both groups. As you can see, it's not matched in both groups, and it should not be matched since it's randomized control trial, or feasibility randomized control trial. We have a response rate of 75 for patients who have submitted their questionnaire after or outcome measures after having the physiotherapy. After that, we have done a process evaluation in one-to-one interviews. The main focus of the process evaluation is just to test if is it acceptable for the patient to be randomized to have MRI or no MRI. So we have interviewed 5 patients and 2 spine surgeons, and the majority of them have questioned being randomized to a non-MRI group. They are suggesting that being in non-randomized, being non-MRI groups will sometimes lose the advantage of having this service and this level, since most of them are from the rural countries around Riyadh, not from Riyadh itself. And even spine surgeons have doubted that such design will be accepted by our patients. So just to synthesize the results, we've found that fear avoidance and anxiety might be the main psychosocial consequences of diagnosing low back pain patients with MRI. The interview study emphasized the importance of local clinical guidelines, since we don't have any local or national clinical guidelines in spinal management or low back pain management. The study also stressed the need for better coordination between secondary and primary care level with the patients, and this could be achieved by having a culturally informed clinical guidelines, local clinical guidelines. The feasibility study suggests that implementation of definitive trial with the current design would counter lots of obstacles. Mainly, we have a time limitation. We have greater number of, we have only 1 recruitment center, and we have no research assistant, therefore that's a lack of funding too. These are the main obstacles for conducting large clinical trial. Adding to this is inacceptability of the patients to be randomized in a non-control group, non-MRI group, sorry. So just to summarize everything that we, in this study, we chose not to go ahead with definitive trial. We are thinking just to have more amendment to the structure of the definitive trial, and therefore to might delay the MRI for a month or so. Then this could be the control group, just to avoid the point of acceptability of patients to be randomized to non-MRI group. Finally, special thanks to those people who contributed to this project. King Fahd Medical City Department of Neurosurgery and Physiotherapy, and also the sponsor, Saudi Spine Society, which sponsored the project. Thank you very much.
Thank you so much. We will postpone all the questions at the end of the session. I have requested my colleague Bara if we can move Mazyed, because both presentations are about low back pain. So thank you, Bara, for giving us this chance. So I would like to introduce Mazyed Al-Ataibi. Mazyed, he's currently he's a PhD student at the Nottingham University in United Kingdom. Mazyed, he is a lecturer in Prince Sultan bin Abdulaziz University since 2013. He has 6 years experience as a clinician, physical therapist in King Fahd Medical City. Also, Mazyed has a master's degree in musculoskeletal physiotherapy from Manchester Metropolitan University in the United Kingdom in 2012. Again, Mazyed is a very well-known physical therapist in musculoskeletal management, and today he's going to talk about the relationship between MRI diagnosis and psychosocial factor and physical therapy treated chronic non-specific low back pain patient, a mixed method study. I would like to welcome Mazyed for his presentation, and I would like Mazyed to stick with the time, please.
Okay.
Go ahead.
First of all, thank you, Dr. Ahmed, for introducing me. The second thing, I think there is a wrong in the title here. My title is Barriers and Facilitator of Activity Normalization for People with Chronic Low Back Pain, Patient and Healthcare Professional in Saudi Arabia.
Still within the low back pain issues?
Yeah.
Okay, thank you.
Yeah. In the beginning, this study has been done as a part of my PhD study. So, low back pain is common, acute or a chronic disorder that affect people from different age and that affecting well-being and work performance. Low back pain prevalence is about 84% in Europe and North America. So, the chronic low back pain prevalence is around 23%, and 12 of them, or 12% of the population being disabled because of low back pain. And also chronic low back pain, it's considered one of the most disabling disorder worldwide, and also considered one of top 10 disease that leading to significant number of disability affecting work performance and well-being. Number of factors associated with development low back pain, such as age, gender, nature of occupation. So, the World Health Organization defines activity normalization as ability to perform physical function and return to work. So, the research gap. UK clinical guidelines indicate how to manage chronic low back pain, but it's appear that low adherence to physiotherapy among patients with chronic low back pain, leading to prevent them and hindering them to resume their former activity and normal activity. US and European clinical guidelines also recommend to screening the patient, any patient with chronic low back pain, from any psychosocial factor, because the psychosocial factor can hinder or prevent them return to normal activity. So, as we know, that psychosocial factor have an impact in return to normal activity and participation, but unclear which specific psychosocial factor that prevent or promote return to normal activity. Research gap in Saudi Arabia. There are many people with chronic low back pain patients in Saudi Arabia. They didn't resume their normal activity because we didn't know, and somehow, you know what I mean, some of them complaining and return, some of them because work issues, some of them, you know what I mean, not adhere to their treatment plan. Insufficient information about chronic low back pain patients in Saudi Arabia. There are lack of study in Saudi Arabia about in what healthcare practitioner and patient with chronic low back pain perceive barriers and facilitators. Also, whether the physiotherapy can influence them to return to normal activity as before. So we come up with two research questions. The first one, what do patient and physiotherapist and orthopedic surgeon perceives as the barriers and facilitators to activity normalization following physiotherapy intervention for chronic low back pain? And the second question was, what are the chronic low back pain patient beliefs about influence of physiotherapy or return to normal activity? So our aims were explore the experience, attitude, beliefs, and perceptions of healthcare professional, physiotherapists, and orthopedic surgeon, and also people with chronic low back pain in Saudi Arabia in terms of barriers and facilitator to activity normalization, and also investigate how beliefs about physiotherapy influence them to return to normal activity. So our study, we utilized mixed methods, sequential exploratory design, that has conducted in two stages. The first stage, it was qualitative one, followed by quantitative. So as you see the diagram here, the phase one, it was qualitative. It has interview and focus group discussion. So from this finding, we're building to quantitative stage, which was survey. So from this to those stage, we gather the finding for interpretation. Ethical approval was obtained from University of Nottingham and King Khalid University Hospital and King Fahd Medical City. So as I mentioned, the first stage was focus group and interview. We design and structure topic guide and semi-structure questionnaires based on our finding from our systematic review and also disability prevention management model. So this data was transcribed and analyzing using framework analysis. So the second stage was survey. We designed a bespoke questionnaire regarding patient beliefs based on our finding from the qualitative stage and our systematic review. Along with that, we involved standardized and validated questionnaires like Roland Morris disability and fear avoidance beliefs. Descriptive and inferential statistics were analyzed to analyze the data by using SPSS. So the qualitative result, one focus group discussion has 7 patients and the other one has 8 physiotherapists, and we did individual interview with 7 orthopedic surgeons. We come up with 7 main factors that facilitating or hindering return to normal activity or activity normalization following physiotherapy. The first one was symptoms control. Second one, patient education and awareness, adherence to treatment plan, psychosocial factor, and the role of a clinician, social support, issue specific to Saudi healthcare system. So the key finding of the qualitative, lack of reassurance, encouragement, education, and awareness to back pain itself were a factor that hindering return to normal activity. Fear of pain and recurrence of injury, conflicting diagnosis between the physician and physiotherapist, ambiguous advice, and complexity of exercise that offered by physio also was hindering patient to return to normal activity. Psychosocial support from different sources was promote or improve the return to normal activity. Also, lack of clinical guidelines and communication between patient and the clinician itself was hindering patient from return to normal activity. Also, healthcare system was a factor in hindering timely treatment due referral system and lack of specialized clinic. So, the second study was the survey. We invited 266 patients face-to-face through the physiotherapy department. Only 178 participate and complete the questionnaires and willing to involved in this study. And our response rate was 66.9. So the key finding of the survey result, socioeconomic factors were negatively correlated with patient belief about fear of pain and pain coping. So when the education and income increase, the patient fear of pain and pain coping get down or decrease. Also, low back pain duration and pain intensity and the pain interfere with normal everyday activity where positively correlate with patient belief about pain coping, fear of pain, conflicting diagnosis, and complexity of exercise. So, psychosocial factor were positively correlated with patient beliefs about importance of clinical guidelines, pain coping, fear of pain, conflicting diagnosis, and the complexity of exercise. So, the research impact. The social implication, people with chronic low back pain are potentially inactive, and they and their family have a poor quality of life, and they didn't contribute to the community, similar like volunteer work or to the society. Society might benefit from retaining those patients to their previous level of productivity to contribute to an economy and the community as well. Economic implication, financial loss to individual and family and society because those patients being sick. People with chronic low back pain may lose earning because they're losing their job. Economy could benefit from returning them to their previous level of productivity to contribute to the economy and workforce. Healthcare service could be benefited from this during reduced waiting time, reduced waiting list, also reduce high return patient rate. So the clinical implication, healthcare professional will benefit from this research because it will highlight the patient beliefs about the treatment they offer and response to it. Patient will benefit from a new evidence-based program and care pathway. So, and then the conclusion was, fear of pain and recurrence of injury, conflicting and ambiguous advice and diagnosis were factors hindering activity normalization. Multidisciplinary team may support patient recovery and activity normalization. Education about importance of physiotherapy may benefit for people with longer back duration. Healthcare practitioner should educate patients that engagement in physical activity will help them to manage their condition, but not increase their disability. Healthcare practitioner should acknowledge the fear and perception of chronic low back pain, which may inform their decision about the treatment they offer to the patient. Recognizing patient perception is critical in designing a treatment and target goal for chronic low back pain rehabilitation. And then I would like to special thanks to Physical Therapy Department and Orthopedic and Spine Department in King Fahd Medical City and Physical Therapy Department in King Khalid University Hospital for supporting me and allowing me to collect the data through their department. Thank you.
Thank you so much, Mazid, for complying with the time. So we are trying to gain more minute.
Okay.
Thank you so much. I will we'll leave the questions at the end of the session. And now we have our next speaker, Bara Yusuf. Bara, he is an occupational therapist working at King Sultan bin Abdulaziz Humanitarian City. Bara, he is a graduate from الجامعة الهاشمية or Hashemite University in Jordan 2004, and he is working in mainly with the pediatric unit. So I would like to welcome Bara to give us a speech about the outcome of cognitive rehabilitation therapy program for children with traumatic brain injury. So welcome, Bara, for your presentation.
Thank you, Dr. Ahmed, for the introduction. For the sake of time, maybe I will skip some of the slides, but inshallah I will give you the conclusion and the summary of this presentation. So my talk will be about the outcome of the cognitive rehabilitation therapy program for children with the traumatic brain injury. The main aim is to give you a model in order to promote the best practice the outline of the presentation, I will start an introduction about the cognitive impairment in children. Then I will talk about the method and the strategies of the cognitive rehab therapy program for children. Then we'll talk about the result and the outcome of the study, and then we will finish with conclusion and give a recommendation for future research. Starting with cognitive impairment in children, for whom who's working with children, we know we have the huge etiology, epidemiology also of the cognitive impairment. But if we categorize all of these cognitive impairment, which we might see in children, it can be under two categories, either congenital cognitive impairment or acquired cognitive impairment. And I use the term brain injury because when we say brain injury, it's referred to any kind or any type of the brain lesion or damage that can occur before or after birth. Congenital cognitive impairment, I guess all of you has seen patients like cerebral palsy, developmental delay syndrome, spina bifida, etc. They might have cognitive impairment, while the acquired cognitive impairment, like a traumatic brain injury, which is our scope, and the non-traumatic, like maybe tumor, stroke, some degenerative disease, etc. So this is just an outline of the cognitive impairment which we might see in children. Now, about the cognitive impairment itself, we have a lot of the cognitive functions, a lot of the cognitive skills, but it can all fit under one of these heading or this category. Attention problem is very common to be seen after brain injury due to the damage, as we know, to the frontal lobe, parietal cortex, especially the posterior parietal cortices. Memory problem also with both type, working memory and long-term memory. It's usually affected after a brain injury, working memory to the damage of the frontal lobe, while the long-term memory, you have many areas of the brain engaged and associated with the long-term memory, like the temporal lobe. We have also cerebellum, basal ganglia with the procedural memory, non-declarative memory, etc. Visual processing also, we see also a lot of the visual processing problem. Damage of the primary visual area can cause maybe an impairment of these skills like visual field acuity, ocular movement, while secondary association cortices, temporal lobe and parietal lobe, where is the visual informations is descent, we might see visual processing problem. The last one is the executive function, and just want to highlight this executive function. Maybe one of the speakers has mentioned about it before. This executive function problem and metacognition usually is very common and very clear and very discrete in patients with the brain injury. And this is sometimes how we recognize the brain injury from the congenital, I mean the acquired one from the non-acquired. Executive function problem due to the damage of the frontal lobe. We know most of the cases which has the rapid acceleration, deceleration, brain damage secondary to the car accident, they might have developed frontal lobe damage and executive function problem, like a problem in goal setting, initiation, inhibition, self-awareness, self-monitoring, etc. So this is just an introduction about the cognitive impairment. Now I will talk about the participant assessment tools, outcome measure, and intervention strategies and technique. In the participant, we have recalled all the data for the children who was admitted within 1 year in Prince Sultan bin Abdul Aziz city in the inpatient unit, and I'm referring here to the new patient because we have many of the patients who is for readmission. And we found that retrospectively we have about 94 children who diagnosed with a traumatic brain injury. Demographically, as we see, we divided them in two groups, 0 to 6, 35 patient, while age from 7 to 14, 59 patient. In terms of the gender, 65 male, while 38 female. The majority of the patient, they have traumatic brain injury secondary to the road traffic accident. And just I want to highlight that because in our finding, it was reported that the majority of the causes, it was road traffic accident. Of course, some of the famous studies has reported about falling, especially from the household furnitures and falling during sport playing, as also one of the major cause of the TBI in children, especially when we add the contagion, because contagion, which is the mild TBI, sometimes is not recognized or not noticed until you make standardized or specific assessment for that. So this is just one of the distinction we make throughout. So again, we have road traffic accident, falling, others like anoxic injury, like maybe drowning, etc. Now, out of those 94 patients, we have selected 25 who met the inclusion criteria. I choose the patient from 7 to 12 years old and has mild to moderate cognitive impairment based in the WFM. Their total score should be more than 15. Now I will talk about the assessment tools and the outcome measure. Now to evaluate the patient progress and to monitor their performance, we have used the 3 outcome measure: functional independent measure WFIM, dynamic occupational therapy cognitive assessment, DOTCA, finally non-standardized assessment. And this standardized assessment was taken at baseline at the admission time and also after completing the rehab program at the discharge. Starting with the WFIM, for whom who's not familiar with the WFIM, it's like a norms scale measuring the functional area of the patient. We have 3 functional areas: self-care, mobility, cognitive. As you see in the table on the right, also under each area we have subcategory or sub-area. This is the average performance of the patient out of the reference range at the admission. This is a self-care, their average performance, 25 out of 56, mobility 19 out of 35, finally cognitive 18 out of 35. Here we can see the performance of all the patient one by one in terms of the self-care, mobility, and the cognitive related to the reference range. The second one, which is the dynamic occupational therapy cognitive assessment, this is a standardized cognitive assessment which is very specific, very detailed, measuring the cognitive function of the patient in 5 areas: orientation, spatial perception, praxis, videomotor, and thinking operation. And the different here we have a 3 age group or reference norms group. Of course, I'm not expecting child of 7 years old to perform same like child with 12 years old. This is why the norms data is different based on the group. And here we can see the average of the performance in the admission and related also to the reference range in all the 3 group. Here again the groups one by one, it's already included. The last one, which is the non-standardized assessment. And I just want to highlight that because sometimes it's not necessary to use a highly sophisticated standardized outcome measure in order to measure the patient performance or progress. So we have set like methodological in order to monitor the patient performance and to have a measurable goals. So we have set a 5-element which is presenting a methodology for setting the goals for the patient and monitor their performance in daily basis or weekly basis. The first one is the type of the task. So every time I see the patient or when I set the goals, I need to identify what is the type of the task I use with the patient. If I use with him attention exercise, memory exercise, even I specify, because the specificity is very important. Is it maybe selective attention, alternating attentions, divided attention, this type of the attention. Complexity of the task, if I use with him simple tasks, complex tasks, I specify also if it is maybe a large shape cancellation, a small shape cancellation, and how many variable. Level of the queuing and assistance needed, how many cues I give to the patient. Type of the strategy employed, because we have many strategy in the cognitive rehab, like in the memory training, we use like errorless learning, chaining, spaced retrieval, etc. Finally, the measurement of the performance, whether it's accuracy, like the number of the mistakes, omission, commission, the speed, the time for how long it takes the patient to perform the task. So I want to argue, and I'm of evidence on that, but if you use these 5 elements, it's very critical for successful any cognitive rehabilitation program. And we found it very useful and extremely helpful in our program. So this is about the assessment tools. Finally, I will talk about the intervention strategies and the technique. We use the 3 types of the approaches, which is based on the evidence: process training, strategy training, and the education. In the process training here, my main aim and my main goal is to improve particular cognitive skills. So here I want to improve attention of the patient. I want to improve working memory of the patient. And it's about remediation the skill and restoring the skill. And of course, you know, it's also has also influenced the brain structures for neuroplasticity, for these morphological changes in the microscopic level of the brain. And in process training, we have developed protocols. I will just show you quickly some of these protocols. Like this is for attention. It's fit for pediatric populations, and it's graduated from very simple task to more complex task, and it's case-by-case basis. This is for executive functions related to the self-awareness, self-regulation, goal setting, initiation, etc. Sequencing also, some sequencing task, visual processing task also. Again, it's graduated from very simple to more complex. We have developed many working sheet and many exercise sheet, even the one which is available on the market. We use it, but again, in the methodological and structural way. This is a child who is doing cancellation to improve selective attention on the left, and the other one doing working memory by using and back training. This is also for self-awareness and metacognitive skills. This is for visual processing and also the attention, categorizing and sorting. This is the second strategy, which is the strategy training. So here, my goal is to compensate for the problem. So the problem still exists, but I'm going to compensate for the problem using particular strategy. We have internal strategy and external strategy. Internal strategy is something inside the patient. So here I want to change the way of thinking about things for the patient. Like maybe learning the patient to encode the information probably and easily for those patients with the cognitive, with the memory problem. So I learn him one of the strategy like maybe association, self-imagery, maybe reverse logical cues, maybe story method, etc. for those children. Into external strategy is something outside the patient, like maybe giving him a device to recall the things, like maybe notebook, electronic device, recorder, etc. Or changing the environment to make it more structured, more organized, less distractables for those patients with the attention problem or information processing problem. Of course, the more severe the impairment, the more the patient tend to be dependent in use external strategy, versus mild impairment, the patient tend to use and has capacity to use more internal strategy based on the evidence. And the first point of decision to whether to use external or internal strategy is the awareness. If the patient is aware, we use internal strategy, and if the patient is not aware, we use external strategy, and this is case-by-case basis. Finally, the education. Again, the main aim of the education is improving the patient and parent awareness about the process of the disease, prognosis, and nature of the disease. Home exercise program based on the cognitive developmental milestone we have developed, and we give it to the parent. We have developed also some brochures, hands out, and also we have developed to evaluate our program and to have feedback from the parent. We have developed like a questionnaire in order to have idea about their suggestion, issue, challenges, feedback, and it was extremely helpful and profoundly useful for our program to improve our program. And the last thing is the result and the outcome. In general, we found that the cognitive rehab program was effective with those children with the traumatic brain injury. Of course, there is a different level of improvement for whom of you who's working with the TBI. You know, sometimes the structure and level of injury is affecting that and contributing on that. Even the date of the onset, the time the patient spent in coma, even the improvement is also driven by some of the psychodynamic at home, the patient compliance, the psychosocial factor. So there is many factors affecting the improvement. And the cognitive also, we can see the difference between the baseline and the discharge. The baseline in the blue color and the discharge at orange color. You can see the difference between both levels. There is improvement. Here we can see in the DOTCA, the other standardized outcome measure. It showed that in the first age group, there is also improvement in all the domains with all the patients. This is the average performance of all of the first age group. And the second age group, there is also little improvement comparing with the first age group. This is the third age group also. The patient has improved almost in all the area of the cognition. This is compelling for all the data in this table in terms of the admission, discharge, and the reference value. Finally, of course, I have some limitation, like this is not an experimental study, and our future research, I have already started with an experimental study, inshallah will be for future research, and hopefully will be presented in future conferences. I don't have control group, and I did not cover also the patient with the severe cognitive impairment. It doesn't mean that we don't have a strategy. We do have a strategy for them, like using procedural learning, but we did not cover in this study. And finally, we can conclude and have a home message that cognitive problem after TBI is seen in the attention, visual processing, executive function, information processing, and affect the daily life function. Standardized assessment and non-standardized is also improvement. Is very important to monitor the patient performance and to measure his performance and to identify the deficit. Process training, strategy training is recommended treatment for CRT. Of course, in CRT, I mean CRT, cognitive rehab therapy. Of course, our ultimate goal is to improve the function and participation. We need more control studies with long-term follow-up period should begin to answer the question whether gain made during rehab will persist over time. Thank you all. Would like to thank for organizing and scientific committee. Have a nice day.
Thank you so much, Bara, for your excellent presentation. Again, the questions will be at the end of the session, and I would like at this moment to call Professor Mustafa Saleh, and Professor Mustafa Saleh will talk about inherited ataxias, diagnostic algorithm, and novel forms. Dr. Mustafa, he's a professor of pediatric and consultant pediatric neurologist at the College of Medicine of King Saud University. Professor Mustafa, he has a very long CV. The things that's paying my attention here is the number of scientific articles is more than 225 in his field. I would like to welcome Professor Mustafa for his speech.
Okay, thank you, Mr. Chairman. Ladies and gentlemen, it's a pleasure to be here and to contribute to this international meeting. In the inherited ataxia, this is the introduction that handicap should not now prohibit anybody to do physical work. And you could see the Paralympics, which was last month. This is the winter one for the handicap. I mean the one with the motor handicap or motor disability, and it should not interfere with any intellectual importance. I mean, 2 weeks ago, Stephen Hawking died. He's a world authority on physics and on the if you could call it in the physics of the universe, if you could call it. And he had a handicapping disease for which he lived for a long time. He started some 40 years ago or more. And this did not prevent him from doing whatever he did in his brain. So cerebellar ataxias are a neurological disorder in which coordination of motor activity is impaired, preventing the execution of fluid movement. And children with ataxia, they walk on wide base because they are not balancing, and truncal instability. And the key assessment of ataxia is through physical examination. So you need the doctor to say that this is ataxia or not. Epidemiology is 1 per 10,000 have got either ataxia, inherited ataxia, or hereditary spastic paraplegia. But why are they important? Because some of them are treatable, and all of the inherited ones are potentially preventable. So if you could get the gene, you can prevent all of them. So this is the importance of knowing them. But you need the doctor to identify whether it's ataxia. And this is why the WHO is now focusing on neurogenetics, because most of the causes of handicap due to infections like poliomyelitis and so forth have vanished now. And now they are left with inherited disease. And this we highlighted this in this textbook, Genetic Disorders Among Arab Populations. And the majority of these are neurobehavioral impairment or the genetic processes. And also you highlighted this in the chapter, 7 chapters on neurology in this textbook of clinical pediatrics. And it comes here from consanguinity. You could see here in this pedigree, 4 brothers getting married to 4 sisters, and they are consanguineous. They had 8 affected children. And you see this in the clinic every day there. So it's a real problem. And the gene pool in the Arab world is the same in North Africa and Arabia. And because this has been, people have been moving for a long time. I mean, you can see here, this is Ibn Battuta. Google has celebrated him a few years ago. He went from Tanja, down to Egypt, down to down to the Arabia, and then Sawakin in Sudan, and then he went down to China. And you could see it in the civilizations. In the temple to the left, this is the pyramid is 300 kilometers north of Khartoum. The entrance of this temple, if you can see it, is the same in its design like the entrance of the temple up in Madain Saleh. So these civilizations were connected. So if you find a gene in Morocco, you'll find it in Sudan, Egypt, and Saudi Arabia. It's the same gene pool. And in some of these, the one in the lower down is a picture which was taken 100 years ago from Sawakin in eastern part of Sudan. And you could see it's Jeddah is a prototype of it. So the same type of buildings. So I mean, these people were moving around for thousands of years. So, and actually we have tracked one mutation in one of the congenital muscular dystrophies, which was found in families in Sudan, North Sudan, and here in many of the tribes, down to 4,500 years. So 4,500 years, they had the same grandfather. And so ataxia is these abnormal movements. You define it by finding these physical signs, and I will not go over it, but the areas which are affected are either cerebellum mainly, but you can affect the peripheral nerve or spinal cord as well. And its prevalence, the genes for it, 42 different autosomal dominant genes, 37 autosomal recessive genes, and 6 X-linked genes. And I guess I will highlight, I'm part of an international work group called SPATAX. This is Spastic Paraplegia Ataxia Consortium. It's an international consortium. They meet in Paris. It's headed by every 3 years. And here they find the genes first, new therapies, new rehabilitation, and so forth. And the good thing about it, patients are part of this group. You could see them there, part of the, this, I'm supposed to be in the second line in this picture. So we had many of these ataxias. Many of them came out to be novel diseases, new diseases, and we published them in Brain. And it was, some of them were also cited in PhD, like this Sasha Vermeer in Holland in her PhD thesis. And how do you know them? I mean, you need to, you need to have the background about it, clinical, and then they are divided into acute or chronic. And the acute ones, the chronic ones are acquired or inherited. And the inheritance, they are either recessive, so both parents are carriers, or they are dominant. And after recognizing the clinical picture, you need to do the right investigation, whether it is MRI, or whether it is neurophysiology, or whether it's a laboratory test, and each of them has got its characteristic one. We worked on, for example, Friedreich's ataxia many years ago with the Swedish group, and and then there are some which you can see from the phenotype. So there's this ataxia telangiectasia. If you see the eyes of this boy, they have these vessels, abnormal vessels, the red ones, and which are here. And there is one which is called ataxia telangiectasia like disease, so which are the same. They have cerebellar atrophy, and there is no mouse here, and they have, but they don't have the telangiectasia of the eyes. And we identified there are only 26 in the worldwide. We have 12 of them in Saudi Arabia. We published this one in Brain, And it is common here. It's a common cause of hereditary ataxia here. And then there is another one called, they call this Saleh ataxia, which we described some years ago. There is an entity called, we published this in Nature Genetics, where TDP1 gene mutation, and it's also you find it in gene reviews, Spinous cerebellar ataxia with axonal neuropathy, SCAN1. A family with a large family with 9 affected with ataxia and peripheral neuropathy. And you could see it here. The cerebellum is atrophied, and they have in the biopsy, they have peripheral neuropathy as well. And the gene was found, it was a novel gene, this TDP1, tyrosine DNA phosphodiesterase. This is why it was accepted and published in Nature Genetics. And it is a DNA repair gene. So then we had this so-called Saleh ataxia. It's in one family, described in one family with the gene, and now a second family also came. It starts with early developmental problem, epilepsy, and then ataxia later on. And the gene was found called rhendotaxin or Rubicon, and also was published in Brain, and it is altered vesicular trafficking. This is the gene function, and it was leads to diffuse distribution and mislocalization of the protein of this gene, and it is published in Cerebellum. We found another one which is also new, and it's called the new form of childhood onset somatic paracerebellar ataxia and epilepsy localized to this area, and this was also published in Brain. They have cerebellar ataxia, white matter changes in the MRI. They have epilepsy, this is the EEG, and they have muscle abnormalities, which is here, and there were three girls and one boy, and the gene was, this is the gene, the protein of the gene, and it's called WOX. Also, this was published in Brain, WOX mutation. And from physical science, you can describe which type of ataxia is it. And we found another one which is also a form which is very common here. They come with ataxia and rigidity. And in this one, there is cerebellar problem and basal ganglia problems. This is why they become rigid, and they develop very bad scoliosis with time. They have optic atrophy, and this was also published in Brain. And there is SPG 35. This is spastic paraplegia number 35, in which also they can have ion deposition in their brain. This was described from Saudi families from our side and from Tunisian families. So it's just the same gene. So how can we prevent it? And this is the end of the talk. Why do we need to first identify the patient that has ataxia? 2, what type of it is it? 3, make genetic tests. If you know, 4, get the mutation. If you know the mutation, because we see in the clinics, and I'm sure you see it in your rehabilitation, disasters. I mean, in a family, 4 affected, 5, sometimes 6, and so forth. And it's very destroying to the family unit. The usual thing is that, as usual, the male, the husband, will blame the wife. She's the cause of the problem, without, although he is a carrier of the gene, and so it leads to family disruption, so separation, and the worst which can happen, and I saw this, if he gets married to another carrier. And I saw one, he got married to his cousin, who is a carrier, and they got another affected child. So genetic counseling is very important. If you know the gene, you can do pre-implantation genetic diagnosis, as you can see it in this diagram. You harvest 5 ova from the mother, fertilize it with the sperm of the father, wait for 48 hours, take one cell, look for the mutation. If it is there, discard. If no mutation, you implant. And so you get normal children, as we could see here. This is a family with 3 affected. All of them died. Oh, the one to the left died. They had a rare disease called one of the disease leads to brain atrophy and epilepsy and calcification. And we encourage them to do pre-implantation genetic diagnosis. They tried it once. They said they will try. They can try the pregnancy, and then you can look for whether the pregnancy is affected or not. But this has to be within 120 days. So that triggered an abortion. So they tried themselves, and they had another affected child who died. So they tried pre-implantation genetic diagnosis, and this was the result. So we published this in the Canadian Journal of Neuroscience. He's now 7 years, this boy, and normal, completely normal. So this is the reward of neurogenetics, and is to see them, and now we are seeing them in the family. Many families, many affected and so forth, now they are doing pre-implantation genetic diagnosis, and they get normal children, and then bring them in the, to us in the clinic. One of my personal rewards is to meet Professor James Watson. He's to the right here. To the left, this is the one who discovered DNA. And he got the Nobel Prize for it in 1962. He visited King Saud University a few years ago, and he gave lectures and so forth. So, I mean, this is my message. Thank you for your attention.
Thank you so much, Professor Saleh, for your excellent presentation and innovation. Our last speaker is Dr. Abdurrahman Asbeheen, and Dr. Abdurrahman, he's an assistant professor in the Rehabilitation Sciences Department, College of Applied Medical Sciences in King Saud University. Dr. Asbeheen, he's a graduate from Loma Linda University, doctor of physical therapy, and also he got his PhD as well. Dr. Asbeheen will be speaking about cross-cultural adaptation of the Arabic version for the stroke-specific quality of life questionnaire. And then we'll have, after the speech, the question, if there is any question. So I would like to welcome you, Dr. Abdurrahman. Hayakallah.
Thank you, Dr. Ahmed, for appreciated introduction. As you can see from the title, the cross-cultural adaptation of Arabic version of stroke-specific quality of life questionnaire. أو باللغة العربية التكيف الثقافي للنسخة العربية من استبيان جودة الحياة لمرضى السكتة الدماغية. Before I start in my topic, I would like to give some background about stroke. According to the World Health Organization, they reported around 15 million patients suffering from stroke yearly, and 5 million out of 15 are suffering from the permanent disability, which means 1/3 of this number are suffering from permanent disability. And according to National Stroke Association, stroke is the 5th leading for disability in the United States. Stroke, of course, is known to have a negative impact on patient quality of life. One of the measurement in English version, the stroke specific quality of life questionnaire, and this questionnaire is measuring the impact of stroke in the quality of life. This questionnaire consists of 49 items covering 12 domains. As you can see here in this table, the domains are mobility, self-care, upper extremity function, energy, work, productivity, mood, social rules, family rules, vision, language, thinking, and personality. SSQL demonstrated very good to excellent measurement properties in English language. No validated Arabic version of SSQL is available. And this is our goal in this study, that to translate it through Arabic to be a beneficial tool to measure the progression of quality of life in a stroke patient. Here in this slide, you can see in the right side part of the questionnaire in English. You can see the questions that you ask the patient, or the patient. The patient asks. You ask the patient, or the patient can write it. The answers based on the scale from 1 to 5. This is basically the idea of this questionnaire. So our aims in this study, the current study was conducted to translate and culturally adapt the SSQL questionnaire in Arabic language. For inclusion criteria, the patient will include it if there is, if the patient diagnosed with stroke or recurrent stroke at least 3 months period to start in this questionnaire. Patient should be able to complete the questionnaire by himself or herself. Patient excluded if there is any problems or any communication problems, such as vision, visual, hearing, or cognitive impairments, which impact the completing the questionnaire. The other point, if the patient is not a native Arabic, so that means that he cannot complete this questionnaire. Native Arabic will mean that the patient is unable to speak or read or write Arabic language prior to the stroke. And the second point, the global, if the patient has any global aphasia or dementia. For the methods, here the steps how we did it for this questionnaire. So we started with the forward translation, meaning that we translated from translators whose mother tongue is English. Next, we have expert committee. We reviewed all translations to finalize the final Arabic version to make sure that all linguistics, conceptual, cultural equivalence to the original English version. Then we started with the pre-final testing when we had 10 subjects for pilot testing to make sure that there is no problems in the questionnaire after translation. For results, we have 2 parts of results. The first part about translations, we don't have any problems in the backward-forward synthesis translation. There was no difficulty, and it was straightforward process. For expert committee, we have also no problems. We had no problems. We reached consensus decision on all items. For the second part of the result, the pilot testing, as you can see here, the demographic information for 10 subjects. The 10 subjects answered all the questions with no noticed problem or any difficulty, especially in terms of cultural adaptation for the SSQL questionnaire. Then we reached to the final Arabic version, the SSQL. As you can see here in this slide, this is the part of the questionnaire. It's similar to the English version I just presented a few slides ago. As you can see here, that each question, the patient answered the question from 1 to 5 according to the level of difficulty in the top of the question. For conclusion, the results show no significant problem in culturally understanding the SSQOL questionnaire. We have another recommendation for this study that we should have, should apply, examine the measurement property of the Arabic SSQOL questionnaire.
Great. Thank you so much, Dr. Abdulrahman. And before we go for the questions, I would like to take this opportunity to thank you all for keeping this session going on despite the limited number of attendees. I think this is, very challenging. That's presenting almost to to ourselves as a speaker. We have only 3 attendees, including, or 4, including the photographer here. So I would like to thank you all. And if there is any questions you might ask, please feel free. We are in a good time, by the way. I mean, we finish on time despite we start a little bit late. And if there is any questions. I got some.
Sure.
Please go ahead.
So I spent many years, over 20 years, in military and public safety. I'm a physician, and with low back pain in both military and public safety, that was one of probably our biggest rehabilitation issue that we had. One of the problems that we had in both settings was that we found that even when patients would not acknowledge that there was a benefit to them for having the low back pain, that was a problem that we had. You know, in the military, you have low back pain, you don't have to go to the field. If you're in the Border Patrol, you don't have to go ride a horse on the southeast border. And I'm just wondering if in your work on looking at the psychosocial aspects of low back pain, if that's getting any consideration, is how do you address the benefits, so to speak, of low back pain?
Mazid, if they want to.
Yeah, I think this is a common concern, but since the data that I gathered is in a hospital that's received non-military subjects, but I think the same thing is happening from my experience. I'm saying in military settings, but the benefit of having low back pain, I think it's because we are over-medicalizing back pain itself. I mean, having too much scans, too much investigation for simple, manageable thing.
Let me add something. I've been working in rehabilitation for the last almost 25 years. And a few months ago, I was assigned to take over the transformation, and I was taking care of primary care in the north of Riyadh and the east of Riyadh. That was 4 months ago. And I was gathering the information. What are the major, disease, the top 5 diagnoses we are having in the primary care center, so we can build a clinical pathway and establishing how can we refer patient to the specialty as soon as possible. And imagine or not, back pain was number 2. Number 1, of course, is the respiratory tract infection. And number 2 was the back pain. And when I was listening to my colleagues, I was saying, oh, how can you, Ahmed, as a rehab background, can help the society in developing a clinical pathway to tackle where is the, how can we, when and how can we refer the patient to the specialty on the right time. So I think back pain in our society, because of our sedentary, lifestyle, I think is increasing more and more. Hopefully, with the new transformation in the country, using walking more now to reach the underground. Hopefully, we'll have less and less. But I was not imagine that almost 25% or around of visit to primary care is because of back pain. Thank you for your question. I have a question to you mentioned about the the outcome in the cognitive depend on the date of onset, and I do agree with you. Still in our society, we don't receive the patient at the right time. So can you comment on this? How's your business at Sultan bin Abdulaziz Humanitarian City, the status? Do you still receiving a new patient or still have, chronic patient?
Actually, this is a good comment from Dr. Ahmed. From my clinical practice and working daily with the patients, we still receiving a lot of the patient, let's say, not on the right time. So we do have some patient with a traumatic brain injury, maybe, or with a cerebral palsy, who come to the rehabilitations maybe 2 years or sometime 3 years post of the onset. Especially for the non-acquired one. Even for the acquired one, some of the family did not bring the patient directly to the rehabilitation center, either Prince Sultan or any center, and this is make the case more complex. Even the intervention and rehabilitation become more difficult, and the outcome will be more limited. So the potential for improvement will be decreased, of course. So this is why we can see there is a different level of the improvement. So the patient who come at the acute level, let's say after the onsets directly, of course they are medically stable, they got better outcome than the patient who come 2 years or 3 years later. And we can see really in our daily practice a significant difference in the improvement, because we know this acquired brain injury, they benefit in the first years or the second years more than.
Well, again, is there any question? تفضلي. اضغط الزر اللي جنبه. يعني نشوف الزر اللي جنبه في زرين. Thank you.
Sorry, I'm Naufal Abed, physiotherapist. I work in Comprehensive Rehabilitation Center. I would like to thank all of the speakers regarding to that lectures, which is useful and very enjoyable. My question to Bara Yusuf, I work with the patient, disabled patient, who IQ less than 50%. And they have also problems in the cognitive and also in the ADL and functional activities. And those patients are chronic cases. So my question is, what's the important things to be started with those cases? I think, for my opinion, to start it with the functional activities at the beginning, or started with the what? What's the main important for me as a physical therapy, and I'm supervisor for the occupational therapy. So that's my question. Thank you.
Okay, this is a good question actually. So the process or the procedure of dealing with the severe cognitive impairment is completely different from the mild cognitive impairment. In the mild cognitive impairment, usually I rely more in the process training. So I have hope or some hope for generalization. So this is why I use some of this process exercise. I will focus on improving attentions, working memory, information processing, etc. But in case of the severe or chronic patients, then I use what we call it procedural learning. So the strategy, which is based, of course, in the evidence for such cases, it is what we call it procedural learning or procedural training. For those patients, you use what we call it task-specific training. Task-specific training, that it's mean that you have no assumption that any of the skill that you will learn or you treat to the patient will be generalized. So no explicit that this skill will be generalized. I want just to improve, like maybe a physical therapy, I want to improve patient ability to transfer. So I use a procedural learning. I learn him transferring and just transferring. I will not use with him this process training for this cancellation task or working memory task. I just focus maybe on the safe transferring or maybe on the feeding by using procedural learning. Procedural learning, usually we rely more on the subcortical structure like the basal ganglia and cerebellum, whose action has better access to it rather than the cerebral cortex. So the patient learn the procedure. And to learn the patient procedural learning, we use what we call a chaining technique, like learning the patient maybe first step, let's say in the transferring, then connected with the second step. When he managed to do the first step, I learn him the second step. When he managed to do first and second step, I go to the third step, etc. So I break down the task in a component. And the last thing in the procedural learning, we use it the errorless learning and also spaced retrieval technique. Errorless learning, that no trial and error. Whenever the patient do any mistakes, directly you correct the mistake. And spaced retrieval, that you do not maybe learn the patient the thing and wait to the next day. If the patient can recall the thing after 1 minute, he can recall it after 5 minutes. So my aim to remember this procedure after 1 minute. Then I move to the 5 minutes, then to 10 minutes. This is why I call it spaced retrieval. So this is the technique which we use with these chronic cases or with severe cognitive impairment.
Okay, thank you so much. Without further delay, I mean, thank you so much for the speaker. Thank you so much for the attendees, and wish you all the best. And see you tomorrow morning.